Hello, my name is Jacob Pilcicki, and for my capstone project, I've been working with Carilion Clinic on a project titled Informing Public Health Decisions, an EMR-driven modeling tool for predicting infectious disease. Influenza is a highly infectious respiratory illness which spreads through microscopic airborne droplets and contaminated surfaces. Droplets are expelled by infected individuals via coughing, sneezing, and speaking. The CDC predicts that anywhere from 9 to 40 million Americans are infected annually, which leads to hospitalizations and deaths across the nation. This is about 8% of the population each year, and with cost in the billions of dollars, as estimated by the National Foundation for Infectious Disease. The objective of this project is to develop a system that uses electronic medical records, EMRs, to model, compare, and predict flu outcomes in Southwest Virginia. This materializes in three main pieces: model creation, a flu prediction system, and an analysis dashboard for public health decision makers and researchers to investigate predicted impacts on Southwest Virginia. The overarching goal of this project is to inform public health. By using historical models alongside current community conditions, we can predict impacts. For instance, if researchers anticipate that next season's flu may resemble the 2017 strain. Acting early is crucial to preparing for patient influx. Examples could be increasing urgent care hours or hiring extra temporary staff. Ultimately, this leads to improving the health of our community by reducing strain on public health services, which leads to less infections and deaths. Electronic medical records, or EMRs, represent a digital collection of patient data. This includes basic demographics and data generated from interactions with Carilion Clinic locations. These records are securely stored and maintained by Carilion Clinic, emphasizing data security and patient confidentiality. Carilion's common, standardized EMR schema ensures consistency, supporting the modeling of multiple flu seasons and potential expansion to other infectious diseases. In working with EMRs for this project, three main limitations were identified. First, EMR flu test data is inherently biased and disproportionately represents groups who are less likely to seek testing. The data was also highly imbalanced, with only around 2% of the dataset marked as positive for the flu. Finally, the scope of this stage of the project was narrow, focusing only on the 2017 flu season. Now for some technical details. To capture interactions in the dataset, models are created using neural networks, which replicate the human brain to learn complex interactions between variables in the data and make predictions. Neural networks find nonlinear patterns throughout multiple data types. This allows for modeling unique seasonal relationships and subtle community interactions. Neural networks also make use of flexible model architectures. Flexibility means that models can be fine-tuned and optimized for EMR-specific data challenges. Another key benefit to neural networks is that they can be saved and retrieved later for generating predicted outcomes. Predictions represent if the model believes a patient would be infected with its flu based on the patient's EMR data. To evaluate the effects of architecture changes, classification performance visuals were used, like the confusion matrix and the ROC-AUC curve. Metrics were also recorded, like precision, recall, and especially F1 score, which accounts for highly imbalanced datasets. Here is a simplified view of the pipeline architecture developed to produce predictions within Carilion Clinic's secure, HIPAA-compliant research environment. The pipeline begins with extracted data from the source data repository, which is managed by the Healthcare Analytics Research Team, or HART. The next steps involve training and evaluating a neural network to develop and store a unique disease model. The disease model is then used to generate predicted outcomes which can be investigated in the dashboard. Drilling down into the model creation aspect of the pipeline, we can see the data is first transformed for machine learning. Examples of some of these transformations are resampling and data encoding. Then, neural networks are trained and fine-tuned to best handle the highly imbalanced EMR data. Finally, models are stored in the model repository and their predictive performance is analyzed. The prediction system begins by filtering EMRs to focus on current population conditions and transforming them to fit the expected format. A historical model is then retrieved from the repository and used with transformed EMR data to predict infections. Finally, the predictions are saved. The dataset represents the predicted impact of a model's historical flu season. This is the interactive analysis dashboard. It allows users to see which age groups and locations are predicted to be the most impacted using heat maps. For example, if older or younger age bands are seen to be heavily impacted, nursing homes or schools can be warned ahead of time and take early precautions. The dashboard also supports drilling into locations at the county level within Virginia. If a particular county is predicted to be heavily impacted, resources could be allocated to there ahead of time. 2 bar charts are also provided, which show the proportion of infections as visits to Carilion locations or the number of Carilion locations visited increase. Correlation in these bar charts could show that infected patients would be increasingly visiting the doctors, indicating a need for increased preparations throughout public health. Now, for the results of the project. Neural network models were unable to achieve significantly better performance than previous year's regression models, which were trained on a different data format. However, when trained on the current data format, neural networks outperformed linear regressions, which shows promise for future tuning. An area under the curve, AUC score, of 0.747 was reached, which is better than a random classifier baseline score of 0.5. However, AUC is greatly influenced by imbalanced data, and low F1 scores in the 0.3 to 0.4 range show that data imbalance was an insurmountable factor. Through confirming the severe impact of the dataset imbalance, the focus has been narrowed for future work. Data preparation techniques, which reduce imbalance, show the most promise. The extensible neural network architecture is best positioned to support future tuning. This third year in the multi-year project has made significant contributions. Firstly, data preparation time has been drastically reduced from 50 minutes to just 6, with model training time being cut in half. The focus on extensibility provides a platform designed for future developments, ready to model and analyze new data from any disease or any year. Lastly, the system is built with a modular and well-documented pipeline design, enabling a single script to convert EMRs into predictions. This project also provided an incredible opportunity to bolster Carilion Clinic's research environment with secure solutions to common research tasks. Next year's project will enhance predictions by improving imbalance through the use of presumed infections, preparing data with additional feature engineering techniques, expanding the scope with new years and diseases, and optimizing model performance over multiple seasons. Are there any questions?